Lewis's Medical Surgical Nursing, 11th edition, Chapter 34, Heart Failure. Heart failure is a complex clinical syndrome that develops in response to myocardial insult. It results in the inability of the heart to provide sufficient blood to meet the oxygen needs of tissues and organs. The decreased cardiac output leads to decreased tissue perfusion, impaired gas exchange, fluid volume imbalance, and decreased functional ability. This chapter discusses the nursing and interprofessional care of patients with HF. The percentage of the total blood volume in the left ventricle, LV, at the end of diastole that is pumped out of the LV with the next systole is called the left ventricular ejection fraction, LVEF. HF manifestations occur due to a defect in either ventricular systolic function / LV contraction, heart failure with reduced ejection fraction, and or a defect in ventricular diastolic function / filling, heart failure with preserved ejection fraction. Heart failure is associated with cardiovascular diseases, CVDs, particularly long-standing hypertension, HTN, coronary artery disease, CAD, and myocardial infarction, MI. HF is increasing in incidence and prevalence. This is partially due to better survival after cardiac events and the aging population. HF is primarily a disease of older adults. The incidence is similar in men and women. HF is a major health problem in the United States. The number of people diagnosed with HF has increased from 5.7 million 2009 through 2012 to 6.5 million 2011 through 2014. That number is projected to rise by 46% by 2030. HF is the most common reason for hospital admission in adults over the age of 65. This places a significant economic burden on the healthcare system. The complex, progressive nature of HF often results in poor outcomes, such as hospital readmissions. Around 25% of patients discharged with a primary diagnosis of HF are readmitted within 30 days. The total cost of HF care exceeds $40 billion annually, though there are half of these costs spent on hospitalizations. Etiology. HTN and CAD are the primary risk factors for HF. HTN is a modifiable risk factor that should be aggressively treated and managed. Long-term treatment of HTN reduces the incidence of HF by 50%. Comorbidities such as diabetes, metabolic syndrome, advanced age, tobacco use, and vascular disease contribute to the development of HF. Other causes of HF include congenital abnormalities, e.g. septal defects, infiltrative cardiomyopathies, e.g. sarcoidosis, infections and inflammatory processes, e.g. viral myocarditis, persistent dysrhythmias, and toxins, e.g. alcohol, drug use, chemotherapy. Any interference with the normal mechanisms regulating cardiac output, CO, may cause HF. CO depends on 1. Preload, 2. Afterload, 3. Myocardial contractility, and 4. HR. These factors affect stroke volume, SV, which is the amount of blood pumped per heartbeat. Thus, the equation CO equals SV times HR. Preload and afterload are discussed in Chapter 31. Any changes in these factors can lead to decreased ventricular function and HF. Major causes of HF are divided into two subgroups. 1. Primary causes, Table 34.1, and 2. Precipitating causes, Table 34.2. Precipitating causes often increase the workload of the heart, resulting in an acute condition and decreased heart function. Genetic link. Several different forms of heart disease are passed down in families. Research suggests that one form of HF partially depends on a genetic predisposition. Mutations in more than 30 genes can cause the familial form of cardiomyopathy, a group of diseases that weaken the heart muscle. These genes provide the instructions for cardiomyocyte, heart muscle cell, proteins, the body's largest known protein, titin. responds to such a mutated gene. Titin mutations impair sarcomere function and disrupt chemical signaling, which negatively affects ventricular structure and stability. Specific genes and gene mutations are linked to the development of HTN and CAD, known risk factors for HF. Research into the effects of gene mutations on the incidence of HF is ongoing. Pathophysiology. HF is a complex clinical syndrome that develops in response to myocardial injury and results in decreased heart function. Manifestations of HF are the result of neurohormonal compensatory mechanisms activated in response to myocardial dysfunction, leading to remodeling of myocardial structure and function. Left-sided heart failure. The most common form of HF, left-sided HF, results either from the inability of the LV to 1. Empty adequately during systole, or 2. Fill adequately during diastole. We can further classify left-sided HF as Hf-Ref, systolic HF, Hf-Pef, diastolic HF, or a combination of the two. Heart failure with reduced EF, systolic failure. Hf-Ref results from an inability of the heart to pump blood effectively. The hallmark of Hf-Ref is a decrease in the LVEF. Normal LVEF is 55 to 65%. Patients with Hf-Ref generally have an LVEF less than 40%. It can be as low as 5 to 10%. Hf-Ref is caused by impaired contractile function, e.g. MI, increased afterload, e.g. HTN, cardiomyopathy, and mechanical abnormalities, e.g. valvular heart disorders. The LV in Hf-Ref loses the ability to generate enough pressure to eject blood forward through the aorta. Over time, the LV becomes dilated and hypertrophied. The weakened heart muscle cannot generate adequate SV, which impairs CO. Because the LV cannot effectively push blood forward, end diastolic volumes and pressures in the LV increase. When the LV fails, blood backs up into the left atrium, LA. This causes fluid accumulation in the lungs. The increased pulmonary hydrostatic pressure causes fluid leakage from the pulmonary capillary bed into the interstitium and then the alveoli. This results in pulmonary congestion and edema. Fortunately, there are many therapies that reduce morbidity and mortality in Hf-Ref. Heart failure with preserved EF, diastolic failure. Hf-Pef results from the inability of the ventricles to relax and fill during diastole. About 50% of patients with HF have Hf-Pef. HTN is the primary cause of Hf-Pef. Other risk factors include older age, female gender, diabetes, and obesity. In Hf-Pef, the LV is generally stiff and non-compliant, resulting in high filling pressures. Decreased filling of the ventricles results in decreased SV. The eventual result of Hf-Pef is the same as that of Hf-Ref, a reduced CO leading to fluid congestion. The diagnosis of Hf-Pef is based on 1. Signs and symptoms of HF, 2. Normal LVEF, and 3. Evidence of LV diastolic dysfunction by echocardiography or cardiac catheterization. Therapies are targeted at reducing underlying risk factors, treating comorbidities, and reducing symptoms. Borderline Hf-Pef describes HF patients with LVEF 41 to 49%. Characteristics and therapies are like those for patients with Hf-Pef. The patient with ventricular failure of any type may have low BP, low CO, and poor renal perfusion. Poor exercise tolerance and heart dysrhythmias are common. The patient may arrive at this point acutely from an MI or chronically from worsening cardiomyopathy or HTN. In both acute and chronic causes of HF, the body's response to low CO is to mobilize its compensatory mechanisms to maintain CO and BP. Right-sided heart failure. Right-sided HF occurs when the right ventricle, RV, does not pump effectively. When the RV fails, fluid backs up into the venous system. This causes movement of fluid into the tissues and organs, e.g. peripheral edema, abdominal ascites, hepatomegaly, jugular venous distension, JVD. The most common cause of right-sided HF is left-sided HF. As the LV fails, fluid backs up into the pulmonary system, causing increased pressures in the lungs. The RV must work harder to push blood to the pulmonary system. Over time, this increased workload weakens the RV and gradually it fails. Other causes of right-sided HF, independent of the function of the LV, include RV infarction, pulmonary embolism, and cor pulmonale, RV dilation and hypertrophy caused by pulmonary disease. Biventricular failure. Biventricular failure includes both LV and RV dysfunction, the inability of both ventricles to pump effectively. Because of decreased contractility, fluid buildup and systemic venous engorgement occur. Inadequate CO results in decreased perfusion to vital organs. Compensatory mechanisms. HF can have an abrupt onset as with acute MI, or it can be a subtle process resulting from slow progressive changes. The overloaded heart uses compensatory mechanisms to try to maintain adequate CO. The main compensatory mechanisms include 1. Neurohormonal responses, renin-angiotensin-aldosterone system, ROS, and the sympathetic nervous system, SNS. 2. Ventricular dilation, and 3. Ventricular hypertrophy. Neurohormonal response, renin-angiotensin-aldosterone system. The ROS is a regulatory system that works to maintain normal homeostasis. The goal of ROS activation is augmentation of preload and ventricular contractility to maintain CO. ROS activation promotes retention of fluid and sodium. The juxtaglomerular apparatus in the kidneys senses decreased renal perfusion from a falling CO. In response, the kidneys release renin, which converts angiotensin to angiotensin 1. Angiotensin 1 is next converted to angiotensin 2 by a converting enzyme made in the lungs. Angiotensin 2 is a potent vasoconstrictor that stimulates renal water and sodium retention and the release of aldosterone from the adrenal gland. Aldosterone acts in the nephron to stimulate sodium retention and potassium excretion and promoting myocardial fibrosis in the failing heart. Continuous activation of the ROS and SNS in HF leads to increased levels of antidiuretic hormone, ADH. ADH regulates water retention by stimulating renal tubular reabsorption. It is released in response to arterial low pressure underfilling via baroreceptor signals. It causes vasoconstriction and increases BP and central venous pressure, CVP. The consequences are fluid congestion and hyponatremia. Chronic activation of the ROS can cause harmful effects, such as cardiac myocyte apoptosis, programmed cell death, hypertrophy, and fibrosis. These cause the burdensome signs and symptoms that develop with HF. Sympathetic nervous system. Baroreceptors sense low arterial pressure, stimulating the SNS to try to maintain CO. Catecholamines, epinephrine and norepinephrine, are released. Stimulation of beta-adrenergic receptors increases HR, chronotropy, and ventricular contractility, ionotropy. Ultimately, chronic SNS stimulation increases myocardial O2 demand on the already weakened heart. Continuous activation of the neurohormonal responses, ROS and SNS, in HF lead to high levels of ADH, endothelin, and pro-inflammatory cytokines. Together, these factors further increase the heart's workload, intensify ventricular dysfunction, and force ventricular remodeling. Peptides and cytokines. Endothelin, a vasoconstrictor peptide made by the vascular endothelial cells, is stimulated by hypoxia, ischemia, neurohormones, and inflammatory cytokines. Although endothelin stimulates contraction in most smooth muscles, it has the opposite effect on the heart, acting as a negative inotrope. This serves to decrease ventricular contractility in the failing heart. Pro-inflammatory cytokines are released by myocytes in response to heart injury, e.g. MI-HF. Two cytokines, tumor necrosis factor, TNF, and interleukin-1, IL-1, further depress heart function by exerting a negative inotropic effect, causing myocyte hypertrophy and apoptosis. Over time, a systemic inflammatory response also occurs. High levels of endothelin and pro-inflammatory cytokines result in an increase in the heart's workload, progressive LV dysfunction, myocyte hypertrophy, and ventricular remodeling. Ventricular adaptations. Dilation. Dilation is an enlargement of the heart chambers. It occurs when pressure in the heart chambers, usually the LV, is elevated over time. The heart muscle fibers stretch in response to the volume of blood in the heart at the end of diastole. According to the Frank-Starling law, the strength of the heart's contraction is directly proportional to its diastolic expansion. The implication is that increased preload, a greater influx of blood into the ventricle during diastole, will cause a more forceful contraction. This increased contraction initially leads to increased CO and maintains BP and perfusion. Dilation starts as an adaptive mechanism to cope with increased blood volume. However, excessive preload exhausts the Frank-Starling mechanism. Cardiac muscle fibers are overstretched, and further increases in preload no longer increase CO. Hypertrophy. Hypertrophy is an adaptive increase in the muscle mass and heart wall thickness as a slow response to overwork and strain. It occurs slowly because it takes time for this increased muscle tissue to develop. Initially, the increased contractile power of the muscle fibers leads to an increase in CO and maintains tissue perfusion. Over time, hypertrophic heart muscle has poor contractility, needs more O2 to perform work, has poor coronary artery circulation, tissue becomes ischemic more easily, and is prone to dysrhythmias. Remodeling. Pathologic ventricular remodeling is an actual change in the structure, dimensions, mass, shape of the heart. Ventricular remodeling in HF occurs over time in response to pressure or volume overload and/or cardiac injury and the subsequent compensatory mechanisms. These include neurohormonal, ET, and cytokine activation, and ventricular adaptations, including dilatation and hypertrophy. This altered shape of the ventricles eventually leads to increased ventricular mass, increased wall tension, increased O2 consumption, and impaired contractility. The actual shape of the heart becomes less elliptical and more spherical. Although the ventricles become larger, they become less effective pumps. The LVEF further declines due to loss of mechanical advantage from altered ventricular geometry. Increases in angiotensin II, aldosterone, and cytokines stimulate collagen synthesis, leading to fibrosis and further impaired pumping ability. Ventricular remodeling is a risk factor for life-threatening dysrhythmias and sudden cardiac death, SCD. Drug therapies to prevent or reverse remodeling and decrease mortality are recommended. This includes ACE inhibitors, beta blockers, and aldosterone antagonists. Beneficial counter-regulatory mechanisms. The body tries to maintain balance through several beneficial counter-regulatory processes. Natriuretic peptides, atrial natriuretic peptide, ANP, and brain B-type natriuretic peptide, BNP, are hormones made by the heart muscle. ANP is released from the atria and BNP is released from the ventricles in response to increased blood volume and ventricular wall stretching. The natriuretic peptides have beneficial renal, cardiovascular, and hormonal effects. Renal effects include 1. Increased glomerular filtration rate and diuresis, and 2. Excretion of sodium, natriuresis. Cardiovascular effects include vasodilation and decreased BP. Hormonal effects include 1. Inhibition of aldosterone and renin secretion, and 2. Interference with ADH release. The combined effects of ANP and BNP help to counter the adverse effects of the SNS and ROS. We can measure serum BNP levels. High serum BNP corresponds proportionally with fluid retention and is a predictor of mortality in HF. Nitric oxide, NO, and prostaglandin are counter-regulatory substances released from the vascular endothelium in response to the compensatory mechanisms activated in HF. NO and prostaglandin work to relax the arterial smooth muscle, resulting in vasodilation and decreased afterload. Compensated HF occurs when compensatory mechanisms succeed in maintaining an adequate CO that is needed for tissue perfusion. Decompensated HF occurs when these mechanisms can no longer maintain adequate CO and inadequate tissue perfusion results. Classifications of heart failure. New York Heart Association classes of heart failure. The NYHA functional classification places patients in one of 4 categories based on physical activity limitation due to symptom burden. NYHA class designation changes based on worsening or improving symptoms. The stages of heart failure. The American College of Cardiology Foundation and the American Heart Association more recently developed a staging system, A through D, that emphasizes the evolution and progression of HF as well as treatment strategies. This system identifies people at risk for developing HF who do not currently have heart disease, stage A. This classification encourages clinicians to actively address the patient's risk factors and treat any existing conditions to prevent further disease progression. This staging system is progressive and unidirectional. Patients advance to a higher, worse stage as the disease progresses. Table 34.3 compares the NYHA classification and ACC/AHA staging system. Clinical manifestations. Acute decompensated heart failure. ADHF is an increase, usually sudden, in symptoms of HF with a decrease in functional status, often requiring rapid escalation of therapy and hospital admission. ADHF is the most common cause of hospitalization for older Americans. The presentation of ADHF typically includes symptoms and signs related to pulmonary congestion and volume overload. Neurohormonal activation leads to impaired regulation of sodium excretion through the kidneys that results in sodium and fluid accumulation. The lungs become less compliant. There is increased resistance in the small airways. To help compensate, the lymphatic system increases its flow to help maintain a constant volume of the pulmonary extravascular fluid. This early stage is clinically associated with a mild increase in the respiratory rate, RR, and a decrease in partial pressure of O2 in arterial blood, PaO2. If pulmonary venous pressure continues to increase, the increase in intravascular pressure causes more fluid to move into the interstitial space than the lymphatics can remove, resulting in interstitial edema. Tachypnea develops and the patient becomes symptomatic, e.g., short of breath. If the pulmonary venous pressure increases further, the alveoli lining cells are disrupted, and fluid moves into the alveoli, alveolar edema. This is accompanied by a worsening of the arterial blood gas values, i.e., lower PaO2, increased PaCO2, progressive respiratory acidosis. ADHF can manifest as pulmonary edema. This is an acute, life-threatening situation in which the lung alveoli become filled with serosanguinous fluid. The most common cause of pulmonary edema is left-sided HF. Other causes of pulmonary edema are listed in Table 27.24. Manifestations of pulmonary edema include acute manifestations of left HF, such as dyspnea, orthopnea, and paroxysmal nocturnal dyspnea. JVD is often present and is the most sensitive and specific sign for elevated LV filling pressures. Coughing may provide an early clue to developing pulmonary edema in patients with chronic HF. The patient is usually anxious and pale and may be cyanotic. The RR is often greater than 30 breaths per minute. You may see use of accessory respiratory muscles. Pink, frothy sputum may be present in patients with severe disease. Auscultation of the lungs may reveal crackles and wheezes throughout. The absence of crackles does not rule out ADHF, as many patients with a history of chronic HF develop increased lymphatic drainage of the alveolar edema. Patient's HR is often rapid, and an abnormal S3 or S4 heart sound may be heard. BP may be high or decreased depending on the severity of the HF. Hypotension indicates severe LV systolic dysfunction and the chance of cardiogenic shock. Cool extremities occur with low CO and poor perfusion. Skin pallor or mottling may be present. They result from peripheral vasoconstriction and shunting of blood to the central circulation. Sometimes hoarseness may be present because of compression of the recurrent laryngeal nerve from an enlarged LA, Ortner sign. Patients with ADHF are categorized into one of four groups based on hemodynamic and clinical status: dry-warm, dry-cold, wet-warm, and wet-cold. The most common presentation in patients with ADHF is the wet and warm patient. A patient is wet due to volume overload, e.g. congestion, dyspnea, but warm due to adequate perfusion, warm skin, positive pulses. Clinical manifestations: chronic heart failure. Chronic HF is a progressive syndrome characterized by reduced CO and an increased venous pressure, associated with underlying molecular changes that result in the death of cardiac muscle cells. The compensatory mechanisms in response to this reduced CO include neurohormonal and hemodynamic reactions to maintain major organ perfusion through vasoconstriction and SNS stimulation, an inflammatory response involving cytokines, and ventricular remodeling. These physiologic responses are responsible for the manifestations of chronic HF. Many therapies for chronic HF work by counteracting these mechanisms. Table 34.5 lists the manifestations of right-sided and left-sided chronic HF. Fatigue. Fatigue following usual daily activities can be an early symptom of chronic HF, as the falling CO cannot sustain activities. Fatigue eventually limits activities. Anemia, common in HF, is another potential cause of fatigue. Dyspnea. Dyspnea is the most common manifestation of chronic HF. It is caused by increased pulmonary pressures from interstitial and alveolar edema. Dyspnea can occur early in the HF disease process with mild exertion. As HF progresses, dyspnea develops with less exertion until dyspnea occurs at rest. Orthopnea, or dyspnea in the recumbent position, suggests HF. Orthopnea occurs due to redistribution of fluid from the lower extremities into the lungs while in a supine position. The dyspnea is usually relieved with sitting up. Asking the patient about the number of pillows used under the head while sleeping or about sleeping in a recliner can reveal adaptive behaviors that aid breathing. Paroxysmal nocturnal dyspnea, PND, is episodic, sudden dyspnea that wakes a patient at night. PND is caused by fluid accumulation in the lungs entering the alveoli while the patient is supine. The patient can awaken in a panic with feelings of suffocation and a strong desire to sit or stand to aid breathing. Cough. A chronic, non-productive cough that is worse in the recumbent position is often associated with pulmonary congestion and can be a sign of HF. Other potential causes of cough include gastric conditions, medications, e.g. ACE inhibitors due to increased bradykinin levels, and pulmonary conditions. Tachycardia. Tachycardia is an early sign of HF. One of the body's first responses to compensate for a reduced CO is to increase the HR via activation of the SNS. At first, this compensatory response has a favorable effect on CO, but over time, persistent tachycardia is harmful and may worsen HF and the accompanying manifestations. Adequate HR control in patients with chronic HF has been associated with better clinical outcomes, including decreased hospitalizations and mortality. Palpitations. Palpitations, or an irregular heartbeat, can occur due to dysrhythmias that occur with chronic HF. Atrial fibrillation, AF, is the most common of these dysrhythmias. Patients may report a fast or irregular heartbeat, a fluttering sensation, or skipped beats that may be intermittent. Palpitations may be accompanied by dyspnea, lightheadedness, or near syncope if the dysrhythmia further decreases CO. Edema. Edema is a common sign of HF. It may occur in dependent body areas. Peripheral edema. Liver, hepatomegaly, abdominal cavity, ascites, and lungs, pulmonary edema, and pleural effusion. If the patient is in bed, dependent sacral and scrotal edema may develop. Pressing the edematous skin with a finger may leave a depression, pitting edema. Accumulation of extravascular fluid in the lower extremities can indicate volume overload and be a sign of ADHF. It is important to note that not all lower extremity edema is a result of HF. Hypoproteinemia, renal insufficiency, cellulitis, venous stasis, cirrhosis, and certain drugs can cause peripheral edema. Changes in urine output. Urine output may be decreased because of decreased renal perfusion. HF patients often develop resistance to diuretics, which can result in a drop in urinary output. Nocturia is the tendency to urinate excessively during the night due to increased renal perfusion in the supine position. Skin changes. A low CO can result in decreased perfusion to the skin of the extremities, resulting in mottling, a blue or gray coloring. A coolness or clammy feeling to touch can occur with poor perfusion. Because tissue capillary O2 extraction is increased with chronic HF, the skin may appear dusky. Chronic edema can result in pigment changes. The skin can become dry from overdiuresis. It is important to recognize integumentary signs of other conditions, such as venous stasis, peripheral arterial disease, and cellulitis. Neurologic manifestations. Dizziness, lightheadedness, near syncope, or syncope can occur due to reduced CO and hypoperfusion to the brain, or dysrhythmias that often occur with chronic HF. Hypotension secondary to HF medications and hypovolemia are common causes of neurologic symptoms in chronic HF. Mental status and behavioral changes. Cerebral hypoperfusion may occur because of hypoxia to the brain from decreased CO. The patient or caregiver may report confusion, forgetfulness, inattentiveness, and restlessness. A thorough assessment is needed to evaluate for possible confounding conditions, including psychologic disorders, especially depression and anxiety, or neurologic disorders such as stroke or transient ischemic attack, TIA. Around 1 in 5 patients with HF have clinical depression, which confers a twofold risk of mortality and higher readmission rates. Patients with psychologic disorders have poorer adherence to treatment plans. All HF patients should be screened for depression or coexisting mental health conditions. Sleep problems. Snoring and daytime sleepiness can indicate sleep apnea, a common confounding condition with chronic HF. Sleep apnea screening questions include those about daytime sleepiness and falling asleep, falling rested in the morning, frequent nighttime awakenings, and history and results of a sleep study. Alternatively, insomnia could be due to psychologic issues, including anxiety or depression, or due to excessive daytime napping. The need to void, often with nocturia, may disturb the patient's rest. Chest pain. Chest pain or angina can be the result of the reduced CO associated with HF compounded with CAD. Chest pain in HF can also occur due to myocardial stretch from volume overload. Careful questioning and assessment will help distinguish among the many potential causes for chest pain in the patient with chronic HF. Weight changes. Many factors contribute to weight changes. Progressive weight gain in the patient with chronic HF may indicate fluid retention. Renal failure may contribute to fluid retention. Abdominal fullness from ascites and hepatomegaly often causes anorexia and nausea. As HF advances, the patient may have cardiac cachexia with muscle wasting and fat loss. This can be masked by the patient's edematous condition and may not be evident until the edema subsides. Complications of heart failure. Pleural effusion. Pleural effusion, fluid between the two tissue layers, pleura, that cover the lung and line the chest wall, is a common complication in HF. Increased capillary hydrostatic pressure in the systemic or pulmonary circulation from HF causes fluid leakage into the pleural space. Pleural effusions may result in symptoms of dyspnea, cough, and chest pain. Pleural effusion is discussed in Chapter 27. Dysrhythmias and Dyssynchronous contraction. Both atrial and ventricular dysrhythmias are common in HF. Structural changes, including myocardial stretch, fibrosis, and chamber dilatation, alter the electrical paths of the heart. Early and delayed depolarizations, both common in HF, can trigger dysrhythmias. AF is quite common in patients with HF, and the prevalence increases as the severity of HF increases. AF occurs when numerous sites in the atria fire spontaneously and rapidly, and organized atrial depolarization, contraction, no longer occurs. Loss of atrial kick during systole may contribute to decreased CO and worsening HF symptoms. AF promotes thrombus formation within the atria. Thrombi can break loose and form emboli, placing patients at significant risk for stroke. Treatment with anticoagulation should be a priority if there are no significant contraindications. Treatment with drugs to receive HR control is important. Restoring normal sinus rhythm with cardioversion and ablation may be considered. Atrial fibrillation is discussed in Chapter 35. An enlarged LV and very low LVEF also increase the risk for thrombus formation in the LV. Anticoagulant therapy may be considered for patients with these problems. Patients with HF are at risk for dangerous ventricular dysrhythmias, e.g., ventricular tachycardia, VT, ventricular fibrillation, VF. SCD, sudden loss of cardiac function due to fatal ventricular tachyarrhythmia, is a major cause of death in the HF population. Patients with HF-REF are at greatest risk for SCD. Guidelines recommend implantation of a prophylactic implantable cardioverter defibrillator, ICD, for patients with an LVEF less than 35% who are NYHA class 2 or 3. SCD is discussed in Chapter 33. Dysrhythmias are discussed in Chapter 35. Ventricular remodeling can lead to dyssynchrony in ventricular contractions. One ventricle may contract prior to the other ventricle, leading to suboptimal ventricular filling, preload, reduced force of ventricular contraction, systole, and severe mitral regurgitation, MR. This worsens HF symptoms. Cardiac resynchronization therapy, CRT, in the form of implantable cardiac devices can significantly improve morbidity and mortality for these patients. Many HF patients receive a combination ICD and CRT device, discussed later in the chapter. Hepatomegaly. HF can lead to severe hepatomegaly. The liver becomes congested with venous blood from right HF or ADHF. The hepatic congestion can lead to impaired liver function. Eventually, liver cells die, fibrosis occurs, and cirrhosis can develop. See Chapter 43. Cardiorenal syndrome. Reduction in CO results in decreased renal perfusion, decreased glomerular filtration rate, and increased serum creatinine. Neurohormonal activation causes sodium and water retention, worsening HF symptoms and renal function. Impaired renal function with HF is an independent risk factor for HF morbidity and mortality. Anemia. The primary cause of anemia in chronic HF is chronic kidney insufficiency due to the renal vasoconstriction that occurs with HF. This vasoconstriction results in reduced erythropoietin production in the kidney, leading to anemia. Excessive cytokine production also can reduce erythropoietin secretion. The anemia itself can worsen cardiac function due to increased cardiac workload through tachycardia, fluid retention, and increased SV. Because anemia can reduce renal blood flow, it adds further stress to the heart and worsens fatigue and other manifestations of chronic HF. Diagnostic studies. Diagnosing HF can be challenging. Signs and symptoms are not highly specific and may mimic many other medical conditions, e.g., anemia, lung disease. Diagnostic tests for ADHF and chronic HF are outlined in Table 34.6. A primary goal in diagnosis is to find the underlying cause of HF. An echocardiogram is a valuable non-invasive diagnostic tool used in patients with HF. The echocardiogram gives information about chamber size and function, LVEF, heart valve function, wall thickness and motion, presence of effusion or thrombus, and intracardiac and pulmonary pressures. This test helps to distinguish between HF-REF and HFpEF. Other useful tests include 12-lead ECG, ambulatory heart monitors, chest X-ray, 6-minute walk test, multi-gated acquisition MUGA scan, cardiopulmonary exercise stress test, cardiac MRI, and cardiac catheterization/angiogram. Polysomnography studies for obstructive sleep apnea may be done. An endomyocardial biopsy may be done as part of a heart catheterization to evaluate for ineffective or infiltrative disease in acutely ill patients who develop unexplained, new onset Hf unresponsive to usual care. Laboratory studies aid in the diagnosis of HF. In general, BNP and N-terminal prohormone or BNP, NT-proBNP levels correlate positively with the degree of LV failure. Levels are temporarily higher in patients receiving Neseritide, Natracor, and may be high in patients with chronic stable HF. So, it is important you know the baseline levels. Increases in BNP or NT-proBNP levels can be caused by conditions other than HF, including pulmonary embolism, renal failure, and acute coronary syndrome. Interprofessional care, acute decompensated heart failure. Mortality and readmission rates for ADHF remain unacceptably high. Professional HF organizations have developed quality improvement initiatives, such as Get With the Guidelines and the Acute Decompensated HF Registry, Adhere, to help clinicians and agencies improve HF outcomes. Goals of therapy for the patient hospitalized with ADHF include 1. Symptom relief, 2. Optimizing volume status, 3. Supporting oxygenation, ventilation, CO, and end organ perfusion, 4. Identifying and addressing the cause of the ADHF, 5. Avoiding complications, 6. Providing patient teaching addressing factors that precipitated HF exacerbation, and 7. Discharge planning. Patients with ADHF need ongoing monitoring and assessment of vital signs, O2 saturation, weight, mentation, ECGs, and indicators of volume overload and decreased organ perfusion. Assessment findings indicating fluid volume overload include edema, ascites, JVD, a positive hepatojugular reflux test, an S3 heart sound, crackles, hypoxia, and worsening renal function. Stable patients with ADHF may be treated in the emergency department, ED, or admitted to a telemetry unit. Assess these patients every 4 hours, e.g. vital signs, pulse oximetry, for adequate oxygenation. Record intake, output, and daily weights to evaluate fluid status. If the patient has dyspnea, place in a high Fowler's position with the feet horizontal in the bed or dangling at the bedside. This position helps decrease venous return because of the pooling of blood in the extremities. This position also increases the thoracic capacity, allowing for improved breathing. If unstable, these patients are managed in an intensive care unit, ICU. In addition to continual ECG and O2 saturation monitoring, vital signs and urine output are assessed at least hourly. Indicators of decreased perfusion include hypotension, decreased urine output, cool extremities, altered mentation, heart murmur, dysrhythmias, and worsening renal and liver function tests. The patient may have hemodynamic monitoring, including arterial BP and pulmonary artery pressures. If a pulmonary artery PA catheter is placed, CO and pulmonary artery wedge pressure PAWP are routinely monitored. PAWP is an indirect measurement of LA filling pressure measured from the tip of the PA catheter when inflated in a capillary artery. A normal PAWP is 6 to 15 milligrams of mercury. Patients with ADHF may have a POP as high as 30 milligrams of mercury. Therapies are adjusted to maximize CO and reduce POP. Hemodynamic monitoring is discussed in Chapter 65. Supplemental O2 is provided to help increase the PaO2. O2 therapy is discussed in Chapter 28. In severe pulmonary edema, the patient may need non-invasive positive pressure ventilation, e.g. bilevel positive airway pressure, BiPAP, or intubation and mechanical ventilation. BiPAP also decreases preload. Ventilatory support is discussed in Chapter 65. Non-pharmacologic therapies. Ultrafiltration, or aquapheresis, is an option for the patient with volume overload when diuretics have not been effective. It can rapidly remove intravascular fluid volume and excess sodium from the patient's blood while maintaining hemodynamic stability. Hemodialysis can be used for volume overload with concomitant renal failure. They are discussed in Chapter 46. Implantation of CRT, a biventricular pacemaker, may be considered for patients with ADHF who meet specific criteria and do not respond to more traditional therapies. In the ICU, mechanical cardiac assist devices are used temporarily to manage patients with worsening HF. The intra-aortic balloon pump, IABP, is a device that increases coronary blood flow to the heart muscle and decreases the heart's workload through a process called counterpulsation. The IABP is useful in hemodynamically unstable patients because it can decrease pulmonary artery pressures and systemic vascular resistance, SVR, leading to improved CO. Ventricular assist devices, VADs, can help maintain the pumping action of a weakened heart. A VAD is a surgically implanted mechanical pump. IABPs and VADs are discussed in Chapter 65. Drug therapy. Drug therapy is essential in treating ADHF. Diuretics. Diuretics are the first line for treating patients with volume overload. They decrease sodium reabsorption at various sites within the kidneys, enhancing sodium and water loss. Decreasing intravascular volume with diuretics reduces volume returning to the LV preload. This allows for more efficient LV pumping, decreased pulmonary vascular pressures, and improved alveolar gas exchange. IV administration of loop diuretics, e.g. furosemide, by bolus or infusion, is preferred. We evaluate effectiveness by increased urine output, decreased symptoms, and fluid weight loss. Serum potassium and magnesium levels are continually monitored. Vasodilators. Vasodilators are used to treat ADHF in the absence of hypotension. IV nitroglycerin, NTG, is a primary venodilator that reduces circulating blood volume. It also improves coronary artery blood flow by dilating the coronary arteries, so NTG reduces preload, slightly reduces afterload in high doses, and increases myocardial O2 supply. Tolerance often develops with continued IV use, requiring higher doses. When titrating IV NTG, monitor BP often, every 5 to 10 minutes, to avoid hypotension. Patients on IV vasodilators may have an indwelling arterial line or continuous non-invasive blood pressure monitoring. Sodium nitroprusside, NitroPress, is a potent IV arterial vasodilator that reduces both preload and afterload, thus improving myocardial contraction, increasing CO, and reducing pulmonary congestion. Complications of therapy include hypotension and, at high doses, thiocyanate toxicity. It is given in an ICU. IV Nesertide is a recombinant form of BNP used for short-term treatment of ADHF after a failed response to IV diuretics. As a venous and arterial vasodilator, its main effects include a reduction in POP and decrease in dyspnea. Because the primary adverse effect is symptomatic hypotension, BP is carefully monitored. Morphine. Morphine dilates pulmonary and systemic blood vessels, reducing preload and afterload. It is often given in small IV boluses for the dyspnea associated with ADHF. Cautious use and close monitoring are advised. Morphine has serious adverse effects, including respiratory depression, which can require mechanical ventilation. Positive inotropes. Inotropic drugs increase myocardial contractility and are used for patients with evidence of cardiogenic shock or with low CO. Drugs include beta agonists, e.g. dopamine, dobutamine, norepinephrine, Levophed, and phosphodiesterase inhibitors, milrinone. Beta agonists are used as a short-term treatment of ADHF. In addition to increasing myocardial contractility and SVR, dopamine dilates the renal blood vessels and enhances urine output. Unlike dopamine, dobutamine is a selective beta agonist that works mainly on the beta-1 receptors in the heart and does not increase SVR. Effectiveness of inotropes is evaluated by assessing for improved CO, BP, urine output, and reduced filling pressures. Milrinone has both inotropic and vasodilator properties. Milrinone improves myocardial contractility, increases CO, and reduces BP, decreases afterload. Like dopamine and dobutamine, this drug is available only for IV use. Adverse effects include dysrhythmias, thrombocytopenia, and hepatotoxicity. Digitalis is a weaker positive inotrope that can be added if symptoms persist after other medications have been started. Digoxin can mildly increase contractility but also increases myocardial O2 consumption. It can optimize heart rate, especially in those with atrial fibrillation. We monitor digoxin levels and make dose adjustments based on renal function. Serum potassium and magnesium levels must be maintained. Current evidence recommends the use of inotropic therapy only for the short-term management of patients with ADHF who have not responded to conventional drug therapy, e.g. diuretics, vasodilators, morphine. Continuous cardiac monitoring is necessary with all positive inotropic drugs as they can cause life-threatening dysrhythmias. Interprofessional care. Chronic heart failure. The evolution of evidence-based medication and device therapies over the last few decades has dramatically improved the potential for better patient outcomes with chronic HF. The Heart Failure Society of America, HFSA, and the AHA have regularly published and updated guidelines on therapies for HF. Specialized inpatient, transitional, and ambulatory HF units have emerged. These units are staffed with interprofessional HF teams. Chronic HF therapies are tailored to the individual patient based on comorbid conditions. The goals of chronic HF therapies include 1. Optimal symptom management, 2. Mortality and morbidity benefit, 3. Minimizing side effects, and 4. Monitoring responses to therapies.
Specifically, these therapies treat the underlying cause and contributing factors, maximize CO, improve ventricular function, improve quality of life, QOL, and preserve target organ function,